Thank you very much for the kind introduction, and I too would like to thank Shafiq and the entire organizing committee for inviting me to be part of this conference. I'm delighted to be here. I'm having a wonderful time thanks to your very warm welcome and very kind hospitality. Now, colorectal cancer is the second most common cause of cancer death in North America and Europe. Rectal cancer varies from colon cancer because it has a variable outcome, and if there's local pelvic recurrence with rectal cancer, it invariably leads to incurable disease. So imaging is critical to pre-op assessment and management planning. So our learning objectives for today will review the TNM staging system for colorectal cancer. We'll discuss the role of CT, ultrasound, MRI, and PET, and we'll highlight considerations unique to rectal cancer. Now, the staging of colorectal cancer has evolved to the TNM, or the tumor node metastasis system. And when you're reviewing a CT scan or imaging related to colorectal cancer, you must describe ideally tumor size, location, depth of local wall penetration, which is particularly important when staging rectal cancer, describe local invasion, invasion of adjacent organs, lymph node metastases, distant metastases, and complications if applicable. So complications such as bowel obstruction, perforation, or abscess formation. Now, to go through the TNM staging system, TIS is carcinoma in situ. T1, tumor invades the submucosa, but not the muscularis propria. T2, tumor invades the muscularis propria, but does not invade through it. T3, tumor invades through the muscularis propria. And T4, tumor penetrates the visceral peritoneum. The end staging, N0, no regional lymph node metastases. N1, metastases in 1 to 3 regional lymph nodes, and N2, metastases in 4 or more regional lymph nodes. And then the M staging, M0, no distant metastases, and M1, distant metastases. You combine this TNM system to give you the stage of the tumor, with stage 1 and stage 2 disease reflecting just the T, the local T stages with no lymph node involvement, no distant metastases. Stage 3 disease has lymph node involvement, and then stage 4 disease has distant metastases. And 5-year survivals based on the stage. You can see stage 1 disease has relatively good 5-year survival. Stage 4 disease has very poor 5-year survival. And you'll note that stage 3A disease has slightly better prognosis than stage 2B disease. So that local invasion, particularly in rectal cancer, is critically important. Now, in our practice and most practices, CT is the primary preoperative imaging modality, and in a study by Mauchley in the American Journal of Surgery in 2005, 130 patients, CT aided operative planning in 33%, it caused surgery to be cancelled in 5%, and qualitatively different care in 16%. So what do you have to do as a radiologist? So a patient has a new diagnosis of a colon cancer and you have a CT scan. Ideally, you'd like to confirm the location of the tumor, although that it's not always visible. Sometimes the endoscopist can get confused. If there's a very redundant sigmoid colon, the endoscopist might believe that the tumor is in the transverse colon, when in fact it's still in the sigmoid colon. And this is very important differentiation, particularly if resection is planned laparoscopically. So if you can, try and identify the location of the primary tumor. Very importantly with colon cancer is to document local invasion, because if that patient goes to surgery, ideally you want the entire disease to be resected at the first surgery. So if there is invasion of local organs, such as the duodenum from a right-sided colon cancer, it's critical that you inform the surgeon of that so an appropriate surgery can be planned, and not an open and closed case with then an attempt at a resection at a later date. So here's an example. This is what the endoscopist sees with colon cancer. It sees the luminal aspect of the tumor, and it's the CT scan with multiplanar images that suggests to us if that tumor is confined to the bowel wall or if there's local invasion. Here's another example, the endoscopist's view and our view with CT. Now, with colon cancer, I don't really make a great effort to distinguish between T2 or T3 disease, because in colon cancer, it probably doesn't matter a great deal to the immediate management of that patient. But if you see soft tissue that's convex externally, as in this case, you can be confident that that is probably T3 disease on CT. Here's another example, the endoscopist's view. It doesn't look very much different to the other cases I've shown you, but in this case we see local invasion of the urinary bladder. So this is the critical importance of CT in colon cancer when staging local disease. Also look for complications. This patient presented to the emergency room with abdominal pain. We did a CT scan. We identified this obstructing cancer in the transverse colon, and it's very easy to feel proud of yourself for identifying that. And then you may overlook the fact that this is a very distended cecum with edema around the cecum. The small bowel is not dilated, so this cecum was in fact undergoing ischemic change at the time of surgery. We had suggested the possibility preoperatively, and this patient had an extended right hemicolectomy. Now, in the case of rectal cancer, it accounts for about 1/3 of all new cases of colorectal cancer, and recurrence is much more common with rectal cancer. The reason for that, it's a much more surgically challenging disease. The tumor occurs in a very confined space. You have the mesorectal fascia, pelvic sidewall, the beta-rani muscles, the sphincters, nerves, sacrum, GU organs, and vessels. And the surgical treatment differs. For carcinoma in situ and T1 disease, generally transanal excision. T2 and T3 disease, either anterior resection or abdominoperineal resection, and for T4 disease, a pelvic exenteration. So the standard approach now is a total mesorectal excision for T2 and T3 disease. And this has implications for imaging, because T3 lesions close to the circumferential resection margin have a much higher recurrence rate and threefold death rate than smaller T3 lesions. And in our practice, if we feel that a patient has T3 rectal cancer or node-positive rectal cancer, all these patients will get a preoperative chemoradiation. In other centers, particularly in Europe, there's more emphasis placed on distinguishing between good and bad T3 disease. So the proximity of the tumor, the closest proximity of the tumor to the circumferential resection margin is critical. So how do you image and locally stage rectal cancer? Well, in today's practice, CT isn't sufficient. So then we have a discussion, should we be using endorectal ultrasound or MRI? And it really depends what your surgeon needs to know. If it's the T stage, i.e. is it T2 or T3 disease, we can have a discussion, and there will probably be local variability as to whether endorectal ultrasound or MRI is better. But if your surgeon is interested on the proximity of the tumor to the mesorectal fascia or the circumferential resection margin, then there really is no discussion, because MR is definitely superior. Now, a few words about endorectal ultrasound for T staging. Its accuracy is about 80 to 90%. There are some limitations between T2 and T3 disease. Ultrasound has a very limited ability to visualize the mesorectal fascia, and it's very limited in nodal staging. Here are some examples. We see this small tumor in the submucosa. It is not invading the muscularis propria, so this is T1 disease. A step up, we see a larger tumor here. There's some local thickening and hypoechogenicity in the muscularis propria, but there's no evidence that that tumor has invaded through the muscularis propria T2 disease. Or this case, where now we have a much larger tumor, it's really hard to distinguish the muscularis propria there as a distinct organ, and here we have a suspicion of some tumor invading through the muscularis propria, which is supported with the use of color Doppler. So this is very good evidence of T3 disease, and you will sometimes see suspicious mesorectal lymph nodes with ultrasound, but they have to be very close to the rectum in order to appreciate them. So, limitations of endorectal ultrasound, there are many. It's a subjective study. There's a big operator variability. It's limited with bulky or stenotic disease. It's limited with very high or very low tumors. We can't see the mesorectal fascia well. Lymph node detection is poor unless they're very close to the rectum, and it involves insertion of an endoluminal device, which can be distinctly uncomfortable for the patient. MR, on the other hand, is a very good modality for rectal cancer. It is very good soft tissue contrast. We can image the entire mesorectum and mesorectal fascia. It does have limitations in distinguishing between T2 and T3 disease, and nodes will be imaged well with MR, but staging is limited based purely on size. So you should add signal characteristics and the margins of the nodes. Are they very well defined, or are the nodes ill-defined? Here's an example of what we can see with MR, a section through the high rectum where we can see three layers, the mucosa and muscularis mucosae, the muscularis propria, and in between the submucosa. CT versus MR, these are different patients, I'd like to advise you, but CT definitely has inferior contrast resolution in general, and you won't get the detail with CT necessary to reliably predict extent towards the mesorectal fascia. A few examples of T2 disease on MRI. You can see a relatively large tumor that's invading the muscularis propria but not extending through it. And then in contrast, T3 disease, where the muscularis propria is discontinuous, and you can see some speculation suggesting that that tumor has indeed invaded through. So this is a little bit more about the circumferential resection margin. You have to try and identify the closest proximity of tumor to the mesorectal fascia. And here's an example of good and bad T3 disease. On your left, relatively good T3 disease, where there's greater than a 5 millimeter distance between the tumor and the mesorectal fascia. And on your right, very bad T3 disease, where the tumor is extended all the way to the mesorectal fascia and causing thickening of it. In many centers, in our center, the case on the left would get chemoradiation, but in some centers, particularly in Europe, that patient would go directly for surgery because there's a 5 millimeter clearance. And in fact, in some centers in Europe now, they're using as little as 1 millimeter of clearance as a primary resectable tumor. We're considering going down to 2 millimeters in our center, but we haven't done that as yet. So a little discussion, endorectal ultrasound versus MRI, T1 versus T2 disease. Our surgeons will still ask for endorectal ultrasound. Remember, T1 disease is transanal excision, T2 disease, anterior resection or abdominoperineal resection. So our surgeons feel that endorectal ultrasound still has the advantage there. T2 versus T3 disease, well, it really depends on the expertise in any particular center. In very good hands, endorectal ultrasound may have an edge, but if you go beyond that and you're staging T3 versus T4 disease, good T3 disease versus bad T3 disease, nodal disease, well then MR is clearly superior than endorectal ultrasound in all those three categories. And that's really what is becoming obvious as being important in deciding whether patients get preoperative chemoradiation or if they go directly to surgery. And that's why all patients in our practice today with rectal cancer will get a preoperative MRI. And then when you're looking for distant metastases, the workhorse there is CT scan, and all patients with colorectal cancer in our practice will have a preoperative CT scan. When looking at nodal disease, just remember pathophysiology. So if it's a low left-sided tumor, distal descending colon, sigmoid colon, rectum, remember to follow the inferior mesenteric vessels. And here's an example of a metastatic lymph node along the inferior mesenteric vessels. It's very important to scroll and look along those vessels. Our eyes are drawn to the retroperitoneum. They go along the iliac vessels on each side. It's very easy to overlook a small metastatic lymph node along the inferior mesenteric chain. This patient had a primary tumor in the sigmoid colon. But here's a case, a large tumor in March 2005 in the sigmoid colon, came for the 6-month follow-up CT, and I was following my own rule of thumb, and there's a nodule along the inferior mesenteric vessels, and I suggested that this was probably a metastatic lymph node, which is an interpretive error often once surgery has been performed, because you have to remember, while you resect that tumor in the sigmoid colon, you also take a fan of mesentery, and this in fact is where the mesenteric vessels were tied off, and it's a granuloma, and this was followed for a couple of years and didn't change. But it's very difficult with CT to distinguish between a metastatic node and a postoperative granuloma. So sometimes, particularly if the CEA, the tumor marker, is up a little, you might want to do a PET CT scan, because I would consider now, if I was reading that case today, I would say there's an equivocal or indeterminate nodule along the inferior mesenteric vessels. Consider CT scan to look for metabolic activity to further characterize. So we see that nodule 2007. Here's a sobering case. This small area, this is again is a follow-up of a left-sided tumor, wasn't appreciated in 2004, wasn't appreciated in 2005. You'll notice there is an interval difference there in retrospect, but this is a blind area. That's why I'm emphasizing this inferior mesenteric chain, and then when the patient came back in 2007. So you have a low threshold for characterizing nodules in this region further when doing post-operative follow-up imaging. Now, low rectal cancers are important when you're looking for nodal metastases, because they differ a little from other colorectal cancers in that they can also drain to the inguinal lymph nodes in addition to the pelvic sidewall and retroperitoneum. And there was a study on PET-CT in 2006 in the Annals of Surgical Oncology that showed that a PET-CT scan preoperatively altered treatment in up to 38% of patients And a large alteration in treatment was due to the detection of disease in inguinal lymph nodes. Here's an example of very low rectal cancer involving the anal region in addition, and when we look at the coronal CT images, we can clearly see extensive necrotic inguinal lymphadenopathy, which was the sole site of metastatic disease in that patient. Hepatic metastatic disease, well, CT is the workhorse. If we're just staging a colon cancer, we will generally just do a portal venous phase CT, but if the patient has known liver metastases and there's consideration for surgical resection, we will generally add an arterial phase because you get better arterial mapping for the surgeon. Detection rate of colon cancer mets with CT is probably in the mid-80s somewhere. It may be a little higher now. False positive rates, though, with CT are run close to 5%. So certainly hemangiomas, pileosis, biliary hamartomas, hemangioendotheliomas can all look very like colon cancer mets, and you may need other problem-solving modalities, ultrasound or MRI, to help you, particularly if the patient is being considered for liver resection. Here's a pretty typical example of a liver metastasis in a patient with colon cancer. If you do have an arterial phase, there will often be enhancement around the rim of the metastasis in the arterial phase. Here's another example, a small subcapsular lesion. This patient had an MR to help clarify. You can see a little bit of high signal on the T2 images, but not very high, and then a pretty typical appearance post-contrast, so a colon cancer metastasis. And this patient also happened to have a PET CT, and we can see activity. PET, I think, is probably much better for extrahepatic disease. It's not reliable for small metastases in the liver, and I think many centers would use a cutoff of about 1 centimeter. Ultrasound is a mainstay in many countries. It's inexpensive, it's no ionizing radiation, it's available, but it does have a lower sensitivity than CT or MR. Again, there's a big operator difference from center to center, and I don't think it's really accepted for preoperative planning. It's a very good problem-solving tool, and some centers, including a small number of radiologists in our center, do some work with microbubble contrast agents, and I'll show you an example of that. If you think a liver lesion might be a cyst and you have the CT scan, then ultrasound is an excellent, quick way to confirm that. You can use the vessels to map the location of the lesion with ultrasound, and you can confidently characterize even small cysts with ultrasound if you have reasonable visibility. Here's another patient. We can see these hypoechoic nodules in the liver, known colon cancer, certainly very suspicious, and this patient went on and had a contrast ultrasound, and the contrast ultrasound has given additional information about colon cancer metastases, because we've always considered colon cancer metastases to be hypovascular. But in fact, they're highly vascular, but they wash out extremely quickly. So if you watch in real time as the contrast arrives, you get very bright echogenicity and then complete washout by around 18 seconds, except at the periphery of the lesion. So if I show you that arterial phase, what we're actually seeing there with that peripheral enhancement is the delayed washout of the rim, because the arterial phase in CT is at about 25 seconds or 30 seconds, usually, depending on your protocol and the center, whereas these metastases wash out very quickly. MRI in the liver, well, spin echo sequences are replaced now by faster sequences, so imaging of the liver is very good. Phased array surface coils, breath hold techniques. There have been advances in contrast agents, sensitivities and specificities, again in the 80s to 90s. Probably not greatly different to CT and CT arterial portography in one prospective study, but I haven't seen CT arterial portography performed probably within the last 10 years. So just standard CT and MR protocols are really very good today. So what is the role of MRI in looking for liver metastases? Again, it's a problem solving tool. It's very helpful with fatty livers if liver resection is being considered. CT isn't as sensitive in that setting, so if somebody has known metastases in the right lobe of the liver and the left lobe of the liver looks clear on CT, but it's a fatty liver, our surgeons will request a liver MR just to be sure that small lesions in the left lobe aren't being overlooked. And some lesions will be shown to be resectable by MRI when they were considered unresectable by other modalities. That's the increased specificity of MRI with small liver hemangiomas primarily. So here's an example on CT. It looks just like the other colon metastases that I showed you, but when you do the MR, it has typical imaging features of a hemangioma with that peripheral nodular enhancement filling in over time and quite bright on the T2 sequence. PET and PET-CT, well, you get anatomic and metabolic data. You can generate quantitative results, which can be very good for staging, but it can also be very good at predicting early response to treatment. So you may see decreased metabolic activity before you see a decrease in tumor volume. Here's an example. If you're going to do PET-CT, you need diffused images. I don't think anybody here would call this recurrent tumor if you just had this image to interpret. So diffused images are critically important where we see increased metabolic activity in this soft tissue on the serosal surface of the bowel in that instance. So when should you use PET and PET-CT? Well, if you have an elevated CEA and you have a normal CT scan and the surgeon is concerned enough, they may order a PET scan, or if there's an equivocal finding on the CT, such as that nodule that I showed you along the inferior mesenteric vessels. If there's recurrent rectal cancer, an aggressive surgery is being considered to treat that local recurrence. Our surgeons will often order a PET scan in an effort to rule out more distant metastases that aren't obvious on CT. Or if you have a very aggressive primary at the time of diagnosis, some surgeons will order a PET-CT. And the early PET literature where PET-CT was performed showed changes in up to 1/3 of patients, but that's probably less today with improvements in standard CT and MR imaging. Now, what about extrahepatic metastases? Well, if looking for lung metastases, CT is the first choice for lung nodule detection. It's highly sensitive, but unfortunately, it isn't particularly specific. And one study by Ginsberg in high-risk oncologic patients with lung nodules 3 centimeters or less in size, and of those 3/4 were less than 1 centimeter in size, 60% of single nodules and 64% of multiple nodules were malignant. So on the contrary, a large number of those nodules detected are benign. So often either, again, maybe a PET scan or time is the way to sort it out. Here's an example, a patient with colon cancer, multiple lung nodules in 2005, and 2 years later, completely stable. So benign pulmonary nodules. Now, there is another difference between low rectal cancers and other colorectal cancers. Remember the groin nodes, metastatic groin nodes. Low rectal cancers can also get pulmonary metastases without liver metastases, because they have a systemic venous drainage. So just another thing to remember about these low tumors. In the last 5 minutes or so, we'll just say a few words about recurrent colorectal cancer. How do you follow patients post-surgery? There's very little standardization. In Toronto, most surgeons follow the CEA. They'll do a preoperative CEA if it was elevated when the primary tumor was present. They have some confidence in using the CEA as a marker of tumor recurrence. And then imaging of the liver. In our center, it's usually with CT. Some centers around the world will use ultrasound along with the CEA to look for recurrence as liver metastases. And what we're using is CT, usually every 6 months for the first 2 years, and then annually for 3 years to hopefully get up to a 5-year disease-free interval. Recurrent rectal cancer, as we said right at the beginning, is generally considered an incurable disease. It's a bad business, and unfortunately local recurrence is relatively common, ranging from 3 to 30% depending on the center, and that recurrence will be isolated and local in 25 to 50% of those patients. Local recurrence is very difficult to detect with CT and digital rectal exam. MR is much superior and is the modality of choice if local recurrence is considered. So when you're doing that follow-up CT on a rectal cancer and you see that presacral thickening, most often it's post-surgical, but if you have a suspicion that it's increasing over time or the CEA is going up, then those patients should have an MRI. And sometimes PET imaging can also have a role at distinguishing between tumor and scar. In this case, this presacral soft tissue thickening was increasing. A biopsy was performed from the right side and was negative, and then a PET CT was performed which showed increased metabolic activity on the left side, and repeat biopsy using the PET as guidance showed tumor recurrence. And here's another example where PET is useful. It's very easy to walk past this soft tissue just along the sacrum on the left side, but with the advantage of the fused PET images, that recurrent disease becomes much more common. And then finally, laparoscopic resection is becoming more and more common, particularly in colon cancers that are just well localized, but always remember to pay attention to the abdominal wall because you can get recurrence at the port sites, and here's an example in the right lower quadrant. Again, if you're working quickly, it's very easy to overlook recurrent disease in less usual places. And there's a nice ultrasound of that lesion at the time of ultrasounded guided biopsy to confirm. So in the last 2 minutes, a few final thoughts, things that have changed a little in our practice in the last 5 to 10 years. And one of them is the concept of multidisciplinary rounds. There's very little standardization in the management of colorectal cancer. So our hospitals have found it very useful to have cases discussed pre-management at multidisciplinary rounds with surgery, medical oncology, radiation oncology, medical imaging, pathology, all present at the table to hopefully offer patients a better management approach. And then the other thing that's changed a little in our practice, at least in the case of rectal MRI, is the idea of structured reporting, where every patient gets a standard structured report. And it's a good reminder to radiologists and to keep a good standard between radiologists that we're all reporting the same thing and we're not omitting important things in our reports. So in summary, the role of imaging in staging and restaging of colorectal cancer is complex. It's not standardized. CT in Canada, at least, is the mainstay, and that's true for most parts of the world. We use ultrasound and MRI as problem solvers. There's an increasing role of MR in local staging of rectal cancer, and I would say that role has increased to the point that every patient with rectal cancer should have an MRI, unless endorectal ultrasound has shown that it's TIS or T1 disease. PET CT, useful for a rising CEA in those follow-up cases if the CT is normal or equivocal, and then PET is also excellent for identifying extrahepatic metastases. And I've included a few references if you hopefully might find that useful. Thank you very much for your time.
Thank you very much.